Know about Wilson's disease. First, I need to know that. What do we all know about Wilson's disease? Maybe the residents can tell.
Disha.
Currently, there is a deficiency of enzyme which is needed for excretion of copper through the liver. So there is accumulation of copper in the liver and other cells like kidney, brain, cornea, and then that produces toxic effects like liver failure.
Okay. So it's basically a genetic disorder. It's autosomal recessive. So both the parents have to be carrier for the child to manifest the disease. So the chance of recurrence in the next child is almost 25% because of the autosomal recessive state. Now it's a disease of copper, so the copper that is absorbed from the intestine, because of that enzyme deficiency, the gene mutation is in the ATP7B mutation that causes the deficiency of the product, and that doesn't allow the copper to be excreted into the bile. If you look at Wilson's disease, this is just a brief history how it was discovered. First was the KF ring, which was reported in the year 1902, and the KF ring is, all our names, terminologies in medical language is based on the authors or the doctors who have discovered them, or on the patient. So if you all discover something, anything, then you can put your name into that. So Kaiser and Fleischer reported this ring in 1902, and they said they saw in patients suspected of multiple sclerosis, basically neuro-Wilson's. Then Wilson identified, this was his MD thesis, and in his MD thesis he identified 4 patients with progressive lenticular degeneration, and he thought it was a familial disease, and that's why it was known as Wilson's. The treatment for it actually came out in 1952 after a lot of years, almost 50 years. And BAL was the first thing that was being used, chelating, any chelating agent. I remember the time when we didn't have penicillamine, we were actually searching for BAL. And the only place that we used to get BAL was Tata Hospital. So we would try to arrange for BAL from Tata and all. Then penicillamine came in 1956, zinc came in 1961, trientine came in 1969 as treatments for Wilson's disease. The gene causing the disease was identified in 1993, and 1994 there are lots of polymorphisms that have been identified. There are almost more than 200 mutations that have been identified till date, and still more being identified all the time. So what happens here? What happens is that the copper is absorbed from the intestine normally. It goes to the liver through the portal vein, and in the liver, through that enzyme, through the gene ATP7B, it forms the enzyme, and ceruloplasmin is formed. So the copper is incorporated into the ceruloplasmin and it goes into the bloodstream. What happens in Wilson's, because that enzyme is not there, the copper will accumulate in the liver. Now the liver will try to compensate by forming metallothioneins, and these metallothioneins will diffusely deposit copper into the liver. So initial stages, when you actually do a liver biopsy, you will not pick up copper in the liver because it's diffusely there. So even if you do the stains, you will not pick it up. It's only when there is overflow and these compensatory mechanisms are overcome that these copper get deposited into the lysosomes, the Kupffer cells, and that's where you see these copper deposits when you do a staining. So that is why we say that Wilson's usually we are not able to diagnose before the age of 3 years. The youngest patient that has been diagnosed till now is around 3 years, symptomatic. Otherwise we don't diagnose Wilson's disease. Now copper is essential, so you just can't stop copper from the diet. You remember Indian diets, we used to have these copper, not for drinking milk, but for drinking water. Even right now, if you go online shopping, you'll get these copper jars for drinking water. So copper in a way is not bad if you have a normal enzyme function that is going on. And in those days when they used to have copper jars, the copper in the diet was less. We never used to eat chocolates. Your major content of copper is your chocolate and dry fruits. So the poor people would not eat dry fruits. There were no chocolates in those days. So they used to have these copper vessels to actually take the intake of copper. So it's an essential enzyme. It's an essential element because it is required for essential enzymes. And what is most important now, if you look at the genetics of Wilson's, everything is now related to the mitochondria. Because this mechanism of copper is actually working at the mitochondria. So there are a lot of various genotypes that have been identified which are causing different phenotypes. Every Wilson is a different disease. Everybody doesn't come in the same way. If you see, sometimes some sibling is very severely symptomatic and the other sibling is absolutely fine. We used to see Wilsons in adults. They used to come at 40 years of age, straight away, first time. So it's very, very rare, vague presentation. So there are different genotypes and it's all related to various aspects of the mitochondria that are affected. So we won't go into those details. But what is important is now they've tried antioxidant therapy also. So they've tried vitamin E in Wilson and they found some response because of the antioxidant damage that has taken place. So as I said, it's an autosomal recessive condition. The chromosome is 13 chromosome, the long arm, and the gene is ATP7B. Okay, this gene becomes, the ATPase enzyme becomes deficient, and that's why the copper is deposited in the liver initially. Then it overflows, then it goes to other parts of the body. So the brain gets affected, the eyes get affected, and the kidneys, and then the skeletal system. So that is why when you have eyes, you have KF ring, copper deposition. In the brain, it has predilection for the basal ganglia. So they come to you like Parkinson-like features. So they may come to you as tremors, or they'll come to you where they start a motion and they can't stop. Mask-like faces also that they have. So they come to you as Parkinsonian-like features. Kidneys, they will come to you as renal tubular acidosis. And skeleton, they come to you as fractures, RTA-related problems. So these are the things that you will see in Wilson's. They also have Coombs negative hemolytic anemia. It's because of the oxidative damage to the RBC membrane that is taking place because of the copper, excess copper. So there is no other mechanism of why there is Coombs negative hemolytic anemia. Coombs negative hemolytic anemia means when you do DCT, ICT, it's negative. But the child is still having hemolysis that is taking place. And why does the ceruloplasmin go low? Now when this copper is, normal function is there, this copper makes ceruloplasmin which goes out into the serum. So normal ceruloplasmin will be about 20. When this copper is not there, it forms apoceruloplasmin, which is a ceruloplasmin without copper, and that gets disintegrated in the serum very fast. So when you diagnose Wilson's, you actually look for low serum ceruloplasmin. That tells you that the ceruloplasmin is low, that tells you Wilson's. If you have less than 5, 100% it's Wilson's. Less than 10, around 70% it's Wilson's. 10 to 15, 50% Wilson's. 15 to 20, around you will be very careful. Now we did a study at here, Nikita had done her thesis on that. And we found that anybody with less than 5 was definitely Wilson's. 15 to 20 we hardly had Wilson's. Even though the books tell you that 20, less than 20 may suggest Wilson's, 15 to 20 we hardly had Wilson's. But most of our Wilson's were less than 15 ceruloplasmin. So that tells you, look at ceruloplasmin as a good marker. We don't monitor serum copper. Okay, one is, the method of measuring serum copper has to be free copper. What we measure is copper with ceruloplasmin and free copper. So it's difficult unless you do the atomic spectroscopy method, which one of the students had done for zinc and copper. That was done only at DARC. So we don't do serum copper. And what is expected? If copper is getting all deposited in the liver, the serum copper is going to be less. When it starts overflowing, that's when the serum copper increases. So serum copper doesn't give me any idea about Wilson's. So we don't really use serum copper. So pathology, as I said, is the accumulation of copper in the liver, and initially because of the compensation, the metallothionein spreads out the copper into the entire liver, so you don't pick it up on the stains. And then when the storage capacity increases, it gets deposited in the lysozymes and the Kupffer cells, and that's when you do the copper stain, you pick it up. Now, because the damage is taking place, initially if you do liver biopsy in a Wilson's disease, you will only see steatosis. So you may get a picture like a NASH. So NASH is not a diagnosis by itself. Okay, what we read in the Western literature that NASH is a diagnosis, but that's obese children. NASH can be part of anything. It can be part of glycogen storage disease. It can be part of Wilson's disease. It can be part of autoimmune liver disease. It can be part of tyrosinemia. It's just an oxidative damage that is taking place. So that will show you steatosis. So it will be a very non-specific finding. Subsequently, as the liver is getting damaged, it will cause periportal fibrosis and then cirrhosis. And cirrhosis is usually macronodular. So this is how you see that stains. You can see those red color stains in the Kupffer cells. This is copper. So how do we suspect? Now I'll just take the case right now that we have. He was a 9-year-old boy born of 3rd-degree consanguineous marriage. So this is one thing. You always ask for consanguinity. He came 3 months back, abdominal distension for 7 months. And so he had ascites for 7 months. He started getting edema in the legs for 2 months. And jaundice was just noticed 2 weeks ago. So remember, here, even though there is liver cell failure that has taken place, the jaundice has not come up so fast. Jaundice takes a long time to come up. So he was admitted outside March and May, diagnosed as viral hepatitis, treated with all the diuretics, but nothing worked. If you see, his weight is 17, which is okay, in the sense it's just borderline. He has jaundice, pallor, ascites. There's no hepatomegaly. So one thing that tells you, if you have a child with ascites and no hepatomegaly, he's gone into cirrhosis. Normally you would have expected the hepatomegaly to be there. Ascites due to any cause, whether it's acute liver injury, like say hepatitis A, or dengue, or leptospira, or it's chronic liver disease, which has decompensated. You should expect a liver to be there. If it's a soft liver, acute. If it's a firm liver, it's chronic. If it's shrunken liver, it's cirrhotic. So here the liver is not palpable. He has splenomegaly. So this tells us that probably he has portal hypertension. And most important is you check the CNS. So you look for those tremors. Ask him to outstretch his hands and tremor. Second thing is ask for the speech. So even when you're monitoring the patient of Wilson's, you look at the speech. Every time he comes to the clinic, you monitor his speech. And third is what you monitor is the handwriting. So every time just ask him to write his name and keep a chart. We've had a lot of Wilsons now who are 20, 22 years. They're working in banks. I remember the time when they were in 10th standard, they could not speak properly because they had neuro Wilsons with hepatic. And they needed a writer. Some of them needed a writer for the exam. But now they are in such a state that they can work in a bank. Some of them are working, one is working in a bank. So all this regresses over a period of time. If you treat them properly, the copper goes away, the damage is not permanent. They can regress. So monitor the handwriting. For neuro Wilson's, handwriting, speech, okay, and the tremors all the time, every visit. For the liver part of it, you are going to monitor the liver function test and all those things. Now this child, something which tells you at this stage you've still not suspected Wilson's. You've just said he's a chronic liver or a cirrhotic liver with portal hypertension, with ascites, with liver cell failure. Here what it tells you, there's anemia, counts are okay, and platelets are low. Anything that gives you an idea what is happening here? Probably hypersplenism, but you have to see a retic count. Yeah, but then you wouldn't have thrombocytopenia. So if you have thrombocytopenia, one good marker of portal hypertension is thrombocytopenia, but always correlate it with your retic count. We have an epidemic of parvovirus right now. This could also be parvovirus. So retic will help you. Then you look at the INR. Normal INR you expect up to. When you don't know the answer, no, there's mumbling. When you know the answer, it's clear-cut answer that I know. So up to 1.3 we take it as okay. So this is definitely D-ring, 1.79. Bilirubin is slightly high with a direct component. Why do we do SGOT and SGPT both? We can straight away only do SGPT. Why waste money? So here you have SGOT more than SGPT. What does that tell you?
SGOT
And SGPT is more liver. SGPT is more than PT, meaning it's more systemic now, not just. Also, OT more than PT is an autoimmune.
No, OT more than PT is hepatitis A, it's alcoholic liver disease, and it's Wilson's. So this gives you an idea that this may be Wilson's. Autoimmune, PT will be more than OT. Okay, so ALT is more than AST in autoimmune. Again, these enzymes are not that high. They are almost 2 or 3 times the upper limit of normal. So this tells you that this is now getting into a burnt out disease. Normally you would have expected it in hundreds or 300, 400 range. The moment it has started coming like this, you are dealing with a burnt out disease. So this is worrisome for you. Alkaline phosphatase is useful in Wilson's. How does it help you? So when a Wilson's is going into liver cell failure, the alkaline phosphatase drops. So there are certain ratios. You look at alkaline phosphatase bilirubin ratio and all that, but in this child, alkaline phosphatase is normal. Okay, so it's not 100% marker that this will tell you, but this really pointed out towards Wilson's as compared to autoimmune. There's always an overlap between autoimmune and Wilson's. Whenever you work up autoimmune, you'll get copper raised. Whenever you work up Wilson's, you'll get autoimmune markers positive. Your albumin is 2.7, so that tells you it's a chronic liver and it's a decompensated liver. So here you have all these features. Now on this you can say this could be Wilson's. Second would be autoimmune, but not your first. Okay, this is a chronic liver because your enzymes have started normalizing almost and albumin has gone down. Ultrasound shows cirrhosis and you know the liver was not palpable, so it's a cirrhotic liver and portal hypertension, Doppler. Now etiological workup. So if you have a chronic liver, you're going to do autoimmune, you're going to do tyrosinemia, Hep B, Hep C and Wilson's. So your ANA is positive. ANA is positive. You do autoimmune markers, so you get IgG very high and asthma is also positive. So will you take this as autoimmune liver disease? You get a ceruloplasmin which is 5.7. I said less than 5 is 100% Wilson's. You're borderline. And 24 hours urine copper. So you are looking at the copper excretion now. Normally you would expect less than 40. Anything more than 40 in 24 hours tells you that there is excess copper. When we were students, we always had to differentiate between ICC and Wilson's. Indian childhood cirrhosis and Wilson's. Nowadays we don't see that problem of Indian childhood cirrhosis. But in those days, we used to see a lot of liver biopsies which used to have copper deposits and not exactly fitting into Wilson's, though the treatment would be chelation. The reason was they used to boil the milk in copper vessels and that used to be the cause of ICC. So even right now if you do use kadai, so not the steel vessel but those copper vessels, and that has come out, then the copper will stick to your food. So your 24 hours urine copper, normally here we usually take anything more than 100 as significant. So if it's more than 100, this is significant. KF ring is absent. Now KF ring will occur 100% in neurobilsins because by now the liver has gone to, copper has gone to every part of the body. It's not necessarily occur with hepatic Wilson's. So if you get a negative KF ring, it still can be Wilson's if it's hepatic Wilson's. But if it has gone to neuro Wilson's, you should get a KF ring. And serum copper we didn't do. So we did a parent ceruloplasmin. The mother ceruloplasmin is normal and the father is borderline. Okay. So even though we say that it is autosomal recessive, you could have heterozygous conditions in which parents, one of the parents may be not only a carrier but a heterozygote Wilson's, and they may manifest a mild disease. So they may have little copper which is being excreted more as compared to normal value, but they are asymptomatic. We have one child who comes, the girl was in another hospital ICU and she was referred here for liver transplant. That was around 3 or 4 years back. And her INR was pretty borderline, 2.5 it remained. And parents were not ready for transplant at that time. That girl's INR took almost 6 months to normalize, and she responded completely well. She's absolutely asymptomatic right now. Only thing was she didn't have a cirrhotic liver. But she had this waxing, waning, ascites coming, going, but she pulled on. The father had to undergo a liver biopsy because his ceruloplasmin was low. He had jaundice twice in the past, and his liver biopsy showed normal, no copper, but 24 hours urine copper was high. So these are these heterozygotes. They are usually asymptomatic. You don't need to do anything for them. But keep in mind that when you're screening, don't tell the parents you're asymptomatic. That's fine. Monitor them. And that's why a donor should be the one who's preferably not a heterozygous when you're going for a liver transplant. So in this child, you have markers of both autoimmune and cirrhosis. So Wilson's. So you're not sure what it is. So you'll end up doing a liver biopsy. This child had steatosis, which is very common with any liver disease. Micronodular cirrhosis with bile duct proliferation. This is classical. Mallory-Denk bodies are seen with Wilson's. So this is classical. And lipofuscin bodies are also seen with Wilson's. That's why the pathologist said that this is Wilson's disease. But again, that doesn't make a diagnosis. Remember, in Wilson's, you don't have a clear cut, okay, this is the test and this is the diagnosis. It is a scoring system that you use. So clinical manifestations, if it's in liver, it can come to you as acute liver failure. It can come to you as chronic liver disease. It can come to you as just ascites with portal hypertension. It can come to you as cirrhosis. So manifestation is varied. It's not one manifestation. If it's bone, it will come to you as RTA, fractures. If it's blood system, you'll get Coombs negative hemolytic anemia. Brain, you get basically globus pallidus involvement, so basal ganglia involvement. Eye, you'll get the KF ring. Sometimes you may get sunflower cataracts. And cardiac, late stages will cause cardiac myopathy, cardiomyopathy. And renal, you will get RTA. So how do we diagnose Wilson's? The first thing that you do is serum ceruloplasmin. ESPGHAN says that less than 20 is what you look. And I told you the reason why. It's because it's apoceruloplasmin that is formed. Serum copper we don't really use because it's going to be low initially and then it's going to be elevated. Some people do use it for monitoring treatment because when you start it's high and then you come down. But I find it very difficult to get a genuine serum copper done, okay, because the method to do it is very different. So the best way to monitor is to do a urinary copper. So when you have diagnosed a Wilson's, how do you monitor the treatment? You start with chelation. You're going to monitor the urinary copper. That tells you the copper is getting washed out from the body. So initially, suppose this child had 150 initially, baseline copper. Initially when you give penicillamine or any chelation, the copper should start increasing. So it should be 300, 400. So then you are very happy. Yes, the copper is going out. Once the copper is depleted from the body, again it should come down. But this way if we monitor, it also tells us maybe he's not taking medicines. Suppose the copper started coming down, urinary copper. You don't know whether he has taken medicines or he's not taken. If he's taken and was compliant, you see the trend, it's come down. If he's not taken, then also the copper is low. So the way to look at it is whether the copper has disappeared from everywhere else. So you look for KF ring. If the KF ring has started disappearing and the urinary copper has come down, that means the copper is gone. If KF ring is still present and urinary copper is low, he is not taking the medicine. So that's the easiest way to monitor these patients. So you take urinary copper. Sometimes you don't get a base cutoff like how we got in this child 159. You will not get it all the time. You will get a very borderline report, say 40 or 50. Then you do a penicillamine challenge. So you give 500 milligram of penicillin in the morning. After 12 hours, you give another penicillamine. And after 24 hours, you start the collection. And you collect for 24 hours and see how much is the copper. Normally, you expect that whatever was the baseline, it should rise more than 5 times of whatever was the baseline. So if the baseline here say was 50, after penicillamine, the copper should become 250. So that tells you that the copper excretion has taken place. It may be Wilson's. And whenever you collect urine, 24 hours urine, always collect in a plastic or a glass bottle. Liver biopsy, nowadays we don't do much liver biopsy because you get genetic tests to do. So if you can't do a genetic test, then you will do a liver biopsy. More important than the staining is the dry weight copper. So when you do liver biopsy, there are two specimens to be collected. One is for histopath and second is on a filter paper for dry weight copper. A lot of times we are, tempted to, if you got a long piece, you want to cut the piece and send one here and one there. But don't do that. You want a big piece because you are going to get 250 microgram per gram of liver. So you want that. So liver biopsy on filter paper, don't put it in formalin. That is one error I think one of the residents had done one time, to send dry weight in formalin. So these are the things you look for. Ceruloplasmin, usually less than 20, less than 10 definitely. 24 hours urine copper, more than 100 is usually Wilson's. And liver copper, more than 250 is what we usually do. Now you have a scoring system. So how do you approach? You don't do a liver biopsy straight away. You do the liver function test. I told you, look at the ALT-AST ratio. Then you look at bilirubin, INR. You do the ceruloplasmin, 24 hours urine copper, look at KF ring. Straight away go for molecular testing. One, you prevent an invasive procedure like a liver biopsy. Second, you have something available for prenatal diagnosis or for sibling screening. Okay, so you can do this and then liver biopsy and liver copper if not available. And then you do a scoring system. So this is the scoring system. So if you have a KF ring, you get 2 points. If you have an MRI suggestive of Wilson's, like your globus pallidum involvement, 2 points. If you have a Coombs negative hemolytic anemia, 1 point. If you have a 24 hours urine copper, more than twice the upper limit of normal, 2 points, or more than 5 upper limit of normal after the penicillamine challenge, 2 points. Liver copper, more than 250, 2 points. Less than 250, but twice, more than 40, you give 1 point. If you have a copper stain positive on liver biopsy, 1 point. Serum ceruloplasmin, less than 10, 2 points. 10 to 20, 1 point. More than 20, none. And if you got a mutation, 2 mutations identified, 4 points straight. 1 disease mutation for identified, 1 point. You need a score, total score of 4. So everybody has downloaded the calculator. All these are there on the calculators. So you all can download the calculator. You don't need to remember this. But this is how you, so Wilson's is not a diagnosis confirmation anytime. A lot of time parents, are you sure this is Wilson? So you can never be sure unless you've done a genetic test. So you always tell, it looks like Wilson's, 99% it looks like Wilson's. You never say 100% it's Wilson's. And then family screening. So you have to screen all the siblings. You have to do ceruloplasmin of the parents. So siblings, what are you going to do? You're going to do the physical examination, serum ceruloplasmin, liver function test. And if you have a molecular test available, then check for the siblings also. You can delay, see, you don't need to do it right in a newborn period because they are not going to be symptomatic. You're not going to start any chelation or anything. So preferably after 2 years of age, you can do the sibling screening. And parents, you have to monitor the liver function test and look whether they are heterotype. So how do we treat? You remove the copper by chelating agents. This is a symptomatic child. Suppose his sibling has Wilson's. Okay, you've just picked it up on screening. His liver function tests are normal. Ceruloplasmin is low. 24 hours urine copper is okay. What would you do? Yeah, so you will only prevent absorption of the copper. You will not give chelating agents. So chelating agents is only when you have high copper in the body. Your chelating agents are basically penicillamine, trientine. Okay, these are the 2 agents. To prevent absorption of copper, you usually have zinc. So that is what you use. Normally, we don't tell them to, you tell them to avoid fish, shellfish, nuts, chocolates. Normally, you tell them to do that. Once they are off that excess copper from their body, they can come back to normal diet. Okay, but tell them to avoid over copper in the diet. And treatment is lifelong. So chelation doesn't go on lifelong. Chelation goes on for some time and then zinc may go on for lifelong. Now these are the drugs. Zinc, there was always a debate which salt to use, whether to use zinc, gluconate, acetate, sulfate, any of the salt can be used. You have these weight bands. So remember, zinc toxicity is also a problem. Okay, so you don't overdose. Otherwise, you'll end up with cardiac issues, you'll end up with azoospermia, infertility. You don't want those issues. So don't over-treat with zinc. Whenever you are giving penicillamine, always give B6, pyridoxine. Don't forget that. Most important thing, these are 15 to 20 milligram per kg. Trientine is also 20 milligram per kg. Trientine has to be refrigerated. It cannot be kept at room temperature. So that is one problem. Trientine is extremely expensive. One box of 90 capsules will cost you around 16,000 rupees. And to say that this is going to be lifelong is a problem. So most of the patients go on penicillamine. Penicillamine is cheaper. Problem with penicillamine, proteinuria is a major problem. Steven-Johnson is a major problem. And some of them get neutropenia or thrombocytopenia. So you have to monitor all these issues. If you get this, you can reduce the dose of penicillamine and keep it at a lower dose. Never start penicillamine in a child who's in hepatic NKF because it will worsen. So never start penicillamine. Safer drug for CNS. Now penicillamine does not go into the brain. So it's not going to remove the brain copper. The only thing that will remove the brain copper is trientine. So if you have a neurovulsins, trientine is a better choice as compared to penicillamine. Now zinc and trientine or zinc or penicillamine should not be given together. It forms a complex that it doesn't work. So you have to keep a gap. Usually I prefer to give zinc before food because you are trying to prevent absorption. So you just give it before food. And penicillamine and trientine can be given either before food or you give 2 hours after food. So if we don't want to give it together, zinc we prefer to give before food, and then trientine and penicillamine 2 hours after food. So you keep a big gap like that. And you, as I said, monitor the urinary copper, monitor the KF ring. Do this at least, copper at least every 3 monthly and KF ring at least 6 months to 1 year, and see the trend, what is happening. Liver function test will usually improve within a year. ALT will improve. As I told you, for that child, INR took almost 6 months to improve. And when will you change a drug? When there is intolerance, like this child will come. He could not tolerate penicillamine. We had to go to trientine for him. So he required a TAP for the ascites, albumin transfusion was given, upper GI scopy, he required variceal blending. He was on zinc and penicillamine and propranolol. Then readmitted after 20 days with irrelevant talk. So he went into a hepatic NKF at that time. Now you're scared of giving penicillamine here. And you're also scared because now he's developed hematuria. So he's off penicillamine and now he's on trientine. 3 months later, he again comes with decompensation. He has abdominal distension, melena, reversal of sleep. So he seems to be decompensating every now and then. His INR doesn't improve. So this is the time when you actually consider whether to take him for transplant or not. Now, at what level? Usually we take INR more than 4 for transplant. Wilson's, we don't keep an INR of 4. We sometimes even do it with 2, 2.5. So what would be our criteria for a transplant? You have a scoring system. So when do you consider transplant? One is you've started chelation but the hepatic manifestations are not improving or they are worsening. So that's one indication. Secondly, never take a neuropsychiatric Wilson's for transplant, severe disease. If he's a severe disease, don't take because that will not improve. And you have a King's College Wilson Index score which can be used for deciding about transplant. So you have a score more than 11, then you consider transplant. So these are the criteria that you look at to decide whether he needs. So this child has something here, INR, so the score is 2. His bilirubin is around here, so 1, so 3. His AST is around this, so again 5. His WBC count is around this, so 7. So, and albumin was low initially, it was year 3. So he was borderline, okay. He comes to around 10 or 11, but the way he keeps on decompensating all the time, and he has a cirrhotic liver, then you consider transplant would be a better option for him. So how do you monitor a patient who's been on chelation? Call them initially 1 monthly, then call them every 3 months. You monitor the urine output, the urinary copper, the liver function test, the CBC, and then as I told you, initially it will increase the copper and then it will start coming down. KF ring you do every 6 months. When you are on penicillamine, watch for proteinuria and look for neutropenia, anemia. Sometimes you may get iron deposition in the liver taking place, and then zinc causes this problem usually. So you want to avoid that, and you look for the KF ring.